Lipping code is a very simple, beautiful. It has a lot of figures, but no details. You can, once you read my lecture, you look at it at Lipping code. Some lectures are beautiful in the Lipping code. But really, if you want good details of pharmacology at your level, is Rangandale. This is what I recommend. Now, Rangandale. I sent it to one of the students. That's why I took the batch leader email, so that anything somebody send me a question, I will share it with the batch leader so that she will share it with you. Now, Rangandale, is it enough? It's basic pharmacology, which is for this year. If you want it more clinically oriented, can we close the door better so the sound, is that okay? Go to Katzung, Katzung. It's more clinically oriented and what you need it, okay? This is, keep them, really are good reference pharmacology book to keep. Lipping code is very simple, and I recommend it only for nursing and like this. It's a very simple one, but the picture it has, really beautiful. It will help you. It's the main one if you want to go and read my lectures. My lectures, by the way, most of it is from Rangandale, but sometimes I go to up-to-date. But there are things, we cannot take it from up-to-date. These are basic pharmacology. Nothing will be changed, okay? The absorption is the same. Distribution the same. It will not be changed. We will not have extra organ or different metabolism, unless if there is something that I want to be aware. Yesterday I checked up-to-date, and usually myself in any upcoming lectures, yours or semester year 3, I'll use up-to-date. Usually after finishing writing my lecture, I go and check up-to-date if there is anything I can add it. I want to remove this one. Okay. Yes. So today we will talk about drug elimination. When we say drug elimination, it's not only excretion. Usually elimination, it covers two: the metabolism and the excretion. Which is you want the drugs to be out from your body, from inside the body to be out. You want the patient to be free of the medication. So you have the metabolism, and the liver is the most important organ that's responsible for metabolizing. When I say this, it means if you have any disease or dysfunction or anything, what does it mean? It will affect what? You have a liver problem. Sabah al-khair. Drink coffee. You have to answer it, and it's very simple. The liver is the most important place where the organ where metabolism occurs. So if you have any liver problem, what do you expect to the drugs? Yes, please. It might be increasing toxicity, depending where's the dysfunction, okay? Or decrease metabolism, so you have more drug in the blood circulation. What else? Or the opposite. Yeah, so this is where it will go toxicity, or it might have, if the faster metabolism, you don't have the enough therapeutic dose to give you the action. So you have to worry with the any patient that having liver function, because mainly it's metabolized, or most of the medication is in the, but you will hear about the kidney and you will hear about the intestine also. Now the excretion, remember, it's the last phase where you want to eliminate the drug from the body. So which one the most important that you will hear about it is the kidney, urinary. But it doesn't mean through the bile, so it means through what? Bile pieces, okay? But most important, I underline liver and the urine. Also remember, you have the lungs as volatile gas with anesthetics. Also, you might have skin, hair, tears, saliva, and milk, and nursing mothers. You will have some elimination of the medication through those one. I just put them. I don't need to give you some example. I gave you some examples today, and I gave some drugs. But later on, you will hear them in the blocks. So remember, not only the liver, you will hear that Yes, it might be metabolized in the kidney or in the intestine, or when you say excretion, mainly you'll hear renally, but you might hear some medication would be through the bile or the other one that I mentioned.
Doctor?
So, yes.
Doctor, the lecture is not recorded.
You don't need to record it. Why they need to record it? This is, I'm against recording. You know what happened yesterday? Year 3, when I asked them, many students, I asked them why you did not attend, okay? They're not answering me. They said, doctor, your lecture is recorded, so why do we need to attend? This is the way they answer me. So if I need people to attend and listen, and I'll bring questions, whatever I'm saying, you are coming, and whoever is opening now their computer attending, they should not be equal to the people they're closing their computer and they're not there and just taking my recording lectures. Is it mandatory to record? No. Mandatory? Did we receive an email that to record or our... Really? Okay, record it. Although I'm against it. You can record it. You record it. It's okay. You're recording it. But and I will check this one. We should not record, honestly, so that you want to make sure that everyone is attending. You're coming from home to attend, and the people at home, at least they are at home, relaxed, having their computer opening, and they should open their camera and interact, and not to leave until I record. If I want to record, why should I come? I'll record and send it to you, right? And Anna, why should I come if I want to record? Anyway, this is what we talk in Pharmacokinetic 1. We covered absorption distribution, an overview of, I just give an overview of pharmacodynamic. The upcoming lecture, which is I think 18 October, I will cover all the pharmacodynamics. In this lecture, we will cover this part, metabolism and excretion. Now, as you see, elimination, and it might be misleading. Elimination, sometimes they say it for the for excretion, but at the end, elimination should cover metabolism. You should metabolize and then excreting it. Now, when we say elimination, as I told you, you might see it under excretion, or they put it metabolism and excretion. This is exactly a just schematic overview of metabolism and excretion. You have the drug, usually are non-polar. If you want to be excreted through the urine, it should be what? More polar. So through metabolism, you are rendering all your metabolites to be more polar. So usually we have phase 1 and phase 2. I'm sure you've taken it from in biochemistry, right? What can you remember? Can someone remember anything? Nothing? Well, that's important here, okay? Remember, these concepts, it's going to continue with you throughout all the pharmacology lecture, because always in the kinetics and dynamics, this is what we cover in upcoming lectures. And if there is something about the medication, if it's orally absorbed or cannot be taken orally, it should be on empty stomach, metabolized by or affected by metabolism, the liver, where it will be excreted. This is where you will hear a lot about it in the upcoming lecture, next term. So you have phase 1 and phase 2. The idea of metabolism of what rendering more polar and more excretable through the kidney. Is that clear? Now, metabolism, let me move this one. Okay. What does it mean, metabolism? It's an irreversible. Now, can I ask you, usually metabolism, does it render all the time your drug into inactive metabolite?
No.
No. Good. Okay. Alhamdulillah. Okay. Expect 3 things. Tell me, if it's an active metabolite, now we have active drug, we went to the metabolism, the normal procedure or the normal process, what should be? To make it inactive, more polar, more excretable. What other, like expect something that will happen through metabolism? Yes, please. So yes, some of the medication, not many, most of the medication, what you hear, it's active medication going to the metabolism. When it goes to be metabolized, it should be rendering it inactive to be excreted. But we have many prodrugs that will render your inactive drug into what? Active one, so that it will be distributed again. What else expect? A third one. An active into more active. So which is, it might be more toxic sometimes. So it's an irreversible transformation of the parent compounds into what? Daughter compounds, into smaller compounds. Usually transformation of lipophilic drugs into more polar, readily excretable products. So you're rendering it into more polar and more excretable, to be excreted by the kidney. Is the main mechanism by which drugs are inactivated. This is the main mechanism how we inactivate drug. However, not all biotransformation results in inactivation. There are drug activity is sometimes increased by metabolism as activation of prodrug. This is a very well-known medication. Uh, I will tell you decarboxylation. During the phases of metabolism, we have phase 1 and phase 2, and in phase 1 we have different step and phase 2 of levodopa to dopamine in neurons. So we cannot give dopamine, we will give them as levodopa. The levodopa is inactive, it should be metabolized to dopamine to give the action. This is one of the examples. So start to remember those, because when I'll bring the questions, I'll bring them for sure from the main things that I need you to know. Now, as I mentioned, the liver, much important than the kidney and intestine, but you might hear some drugs that are inactivated in kidney or intestine. The liver is the major site for drug metabolism, but specific drugs may undergo biotransformation. By the way, in the book while you're reading, you might read biotransformation, which is also is metabolism in other tissues. For example, I give you an example, digoxin. Digoxin is a cardiovascular drug. You will hear about it when you take cardiovascular pulmonary blood. Gets metabolized in the stomach and intestines. So we have different. Most of the medication, they are rendered what? Inactive. Some of them, we should give them as a prodrugs, and then will be activated into the active drug, like I'll tell you the levodopa to give you the dopamine in the neurons. And then, as we mentioned, the liver is the main site of biotransforming or metabolizing the drug, but you might have certain drug like the digoxin will be through the stomach and intestine. Drug metabolism usually involves phase 1 and phase 2, where I put it in the picture, phase 1 and phase 2. This is phase 1 and phase 2. This is your drug, which should go, the normal process should go to phase 1 and then phase 2 and then excreted. But always we have exceptions, okay? Now in phase 1, what we will have? Oxidation, reduction, hydrolysis. Where in phase 2, we will have conjugation with glucuronide, sulfate, methyl, or whatever. I will tell you which are the most important and which are the most common in those phases. Now, in some drugs, they might be excreted and changed. Some drugs, there is no something that I can say for you to apply to all drugs. So most drugs, they go phase 1 and phase 2. Some of them, as you see, they go directly to what? Phase 2. Some of them, they'll be directly excreted, but these are exceptions. Usually you follow, which is phase 1 and phase 2, to be excreted. Phase 1, you cannot remember those from biochemistry. Doesn't ring any bell. Corona time. انتوا اخذتوا البايوكيمستري بالكورونا؟ No. Yes. Okay. Now let's talk about phase 1. Phase 1, it will convert lipophilic molecules into more polar molecules. So remember that what we are aiming to bring it more polar. Usually, I put it in green, is we need to decrease the activity. But sometimes we heard that we have prodrugs, we can increase the activity or leave the drug pharmacological activity unaltered. As we said, they can be excreted and altered. Reaction involved are catalyzed. Don't tell me you cannot remember. Our most important enzyme, the cytochrome P450. Can you remember cytochrome P450? What is it? That's try something else. Do they have one isoenzyme? Enzymes, one enzyme? Is it one family? Anything about P450? I think it's very important. You have to remember cytochrome P450. You will hear it in each and lecture will be given later. Okay, so because any mutation in their isoenzymes, I'll just give you one example, which is the general, but so that you know why now we are into pharmacogenetics. Now, I remember at King Faisal Hospital, I have one project with one of the cardiac, with liver, with kidney. And you take two patients and you do kidney transplant or liver transplant to both patients. They're all good. They're doing great. They're taking the same medication. Let's say the immunosuppressant, and all of a sudden one will do great and he will be fine, and the other one, he will fail to respond to immune suppressant medication. What would be the reason nowadays, what you hear about it mostly? Mostly now, what's the era of the medicine? نمسيب I'm psychological. لا era now of genetics, personalized medicine, precision medicine. It's pharmacogenetics. Now they're trying to find why these people they respond differently to medication. They're trying to find, and I remember I was working in the Saudi human genome, where we take samples from the Saudi population and trying to find a common mutation that we have it in the population. Now in the States, later on, which medication can be warning a black box they will have, that if you have this mutation, they will put it for you. Avoid taking the medication. If you have this mutation, you have to increase the dose or alter the dose. So the patient, he might go into severe side effects, or he might not respond to the medication, although they are taking the same therapeutic dose. They are trying to find, is this mutation in certain isoenzymes that will affect the metabolism? So it's mutation within this CYP450. So remember, you will hear it. Did you take the genetic?
Yeah.
Dr. Zuhair, they didn't mention about those. Nothing about mutation. Let me. So what's mutation? What will affect? If I have mutation now, I might have a mutation, by the way, but that's wrong. Nothing. But when it will show? Did they tell you? I might live and pass away without knowing that I have a mutation in a certain gene. But when it's important, this mutation, to know about it. Yes, so it might be when you're taking a certain medication, and I might not take this medication forever in my life, but if another person, if they have this mutation and they take this medication and they have mutation in this gene, so you might see the effect. This is what's called pharmacogenetics, which is relating the genetic population and how pharmacology is responding, or how the patients are responding. Now remember, the state, they're looking for their own genetic mutation. Let's see if they found a medication that's in relation to their genetic mutation. Do you think it will be also a good one for us as in the Saudi population, especially for the population is very high, 33 million? Will it be the same? Expect, because of consanguinity, we have different mutation and difference, okay? So it will not be the same, whatever they're warning, it will be. So we have to look for at least the Gulf area or in Middle East, what are the most common mutations.